working together and working online. A number of things just to say. Try and put yourself on mute other than when you want to ask a question. I'll try to make sure we keep to time with my colleagues so that you're in and out of this discussion, but you can make there's time for you to contribute your questions. Please use the chat function if you've got anything you want to say immediately. There'll be some time during the presentation for to recap on what we've heard and also to ask some questions. And there are some questions for you towards the end. It isn't just myself and Natalie talking at you right the way through this. Just go through the agenda for the next slide. So I'll do a little bit about the overarching perspective of the session. Then Natalie and myself will cover the presentation. There'll be a number of breakout virtual rooms for you to have a conversation, and there'll be a conversation back together in this group as one. And the aim is to wrap up the session at just before noon today. Next slide, please. So what's the aim of today? So first of all, it's to update you on our early thinking around how we're developing our approach to regulating health and social care. It is true to say that this is not part of formal consultation yet. We haven't got to that stage yet. That starts in January. But we wanted to talk to you about some of the things we were thinking about and the implications of those things to get your views early. Also, it's an opportunity to hear some of your views about our role and what our priorities should be moving forward. To give you a sense of the timeline, which is the next slide. So we're currently in this sort of between phase 3 and into phase 4. So looking about, we've as you probably know, we've rolled out our emergency support framework and our traditional approach to regulation, and we're going to start the process of formal consultation probably at the end of January. So this is our opportunity to see what's worked well around some of our emerging thoughts around our support during COVID, what we'd like to take forward into the consultation that's formal and into our ways of working moving forward, and also what we learned that perhaps hasn't worked and we don't want to do. We don't want to take it to our methodology moving forward. Next slide, please. Key thing, I guess, for me is that our purpose as an organisation hasn't changed. We need to make sure that we continue to support organisations to improve and also to make sure services are safe. But we want to adapt our ways of thinking. We want to adapt our thinking, particularly around how we use information collectively together across different channels and different organisations, and also how we hear the voice of people who use services, hear the voice of frontline services as frontline service providers, so we can support them to improve safe. But we will still continue to regulate as we have done. But the nature of how we regulate and how we provide that, what hopefully will amount to an always-on view of quality, can change and adapt in the coming weeks and months. Next slide, please. So we do have to respond. There are 4 themes of our strategy, of which this is one. Around people and people who use services, around how we make sure services are safe, and particularly how organisations learn from their mistakes and learn from things that haven't gone well. The idea of a notion of an organisation that doesn't do anything wrong is very unlikely, but safe is as much about how organisations learn and improve. And the last one is about how do we encourage that improvement? What's the alliances that we might form in different sectors, in different industries? We regulate 18 different sectors, of which some have natural improvement partners in things like NHS improvement, where in other sectors like adult social care, there are less obvious support partners for improvement. So how do we collectively work together to drive that, to drive the change that we want to see? Okay, the next slide, I think, Natalie, is where I hand over to you. Is that right?
Yeah, that's right. Thanks so much, Chris.
Okay.
So I'm sure ahead of today you've all had a chance to have a look at our strategy discussion document. So I'm not going to spend too long kind of revisiting the smarter regulation theme, but I did just want to start us off with a little bit of a reminder. So we want to be smarter in how we regulate with, like Chris says, an ambition to provide an up-to-date, consistent and accurate picture of the quality of care in both services and in local areas. We know that this can help people make choices about care, it can guide services and commissioners to drive improvement, and it enables us to be a more flexible and proportionate regulator. This means that we need to develop a much more dynamic approach to regulation. We want to move away from relying on periodic inspections of services to using information from all sources to continually assess quality and update our ratings. We know that data will need to underpin our activity, allowing us to understand risk and how people are experiencing care, as well as targeting our resources so that they have the greatest impact. And ultimately, we want to be much more proactive in the future. In particular as well, we really want to make better use of information and how we share it with others to reduce the duplication and burden for services with the mantra of collect it once and use it many times. Along with that as well, we really want to make it easier for services to work with us through open, ongoing and constructive relationships that are based on trust and our common drive to improve people's care. If we can move on to the next slide, please. Fantastic. So what does success look like for smarter regulation? I think there were kind of a few key points that I really wanted to highlight ahead of us moving into a discussion period. So firstly, around kind of building the foundations of smarter regulation. We know that partnership is going to be key here. So we need to maintain and build partnerships to access the voice of people. So people are using and accessing regulated services 24/7 across England. How do we harness that? And how do we do that in new and exciting and innovative ways that really give us a great insight into quality? We also know that we need to build partnerships with partners across health and social care to access and use data from other sources. So we know from working with and listening particularly to providers over the past few years that there's a real opportunity here to reduce the regulatory burden by working better with partners across health and social care. And we're really viewing that as a priority for our next strategy and its implementation. Alongside that, we need to use SMART and really evolve some of our ways of working. The first, I think this is a real fundamental around how do we move to that space where we're creating an up-to-date view of quality. So we want people to be confident in the knowledge that our assessments are reflective of the care that they can expect to receive on any day where they're experiencing or accessing services. That's really important when we're thinking about smarter regulation. Connected to that is this idea of the right action at the right time and using a diverse regulatory toolkit. So there was something I really wanted to kind of pull out strongly here, is that being smarter doesn't mean that we're not going to cross the threshold and undertake inspections. But what it means is that we want to be using our inspection powers in a much smarter way, and that our visits are targeted and powerful with a sharp focus on what we really need to be looking at. So, for example, rather than spending time looking at paperwork, which could be done remotely, we really want to make sure that when we're on site, we're focusing our time with people using services, staff, and with providers on those real human-to-human interactions. I think as well that takes us on nicely to the next point, which is about those strong relationships with providers. We know that this is going to be really vital to us being able to enable effective and proportionate regulation and to focus our regulatory work on those providers or areas where quality is really needing to improve. I think it's may sound a bit cliche, but it really brings us back to that idea of right touch regulation, which I think is just so important here. I think finally as well, it's just important to recognise that across all of this, there's a huge amount of work for us to do to build our systems, capabilities, our people, our processes, to ensure that we can truly be that flexible and responsive regulator, and that we can stay true to our purpose of keeping more people safe. If we can head on to the next slide, please. So, as Chris said, we're really hoping for some powerful and kind of diverse discussions in the breakout groups that you'll be heading into shortly. In those breakout groups, we've got 3 questions that we'd like you to spend some time discussing as a group. The first is around how do we best focus on what matters most to the public, as well as those aspects which have a positive effect on quality. The second is pulling us back to that idea of an up-to-date view of quality. How do we evolve our rating system to ensure that it's fit for purpose, it's up to date, and again, it focuses on what matters most. And the third, and this is particularly for our provider groups who are with us today, how can we best work with systems partners to make sure that we're achieving that aim of collect once, use many times? So really looking forward to hearing feedback from you all. You'll be in groups with CQC facilitators and note takers who will be guiding you through those conversations. So we'll be heading over there shortly. But I think before we head into those breakout rooms, we'd just like to pause for a few moments just to see if there's any questions that would be helpful to answer before we head into those rooms. Anything coming through on the chat, and I think Chris is going to join me for this bit as well. So Steph, is there anything coming through that would be great to pick up before we move into the breakouts?
So there's nothing in the chat at the moment, but people, please feel free to kind of use the raise hand function and ask a question for Natalie or Chris before we head into the breakout rooms.
The main benefit of this is obviously the questions hopefully will help us develop our thinking around the strategy, but there may be some things that we've said here that just don't make sense to you, or you want further clarity on before we go into those sessions. So feel free. There aren't any questions, mainly because I've asked quite a few of them myself already. What has CQC stopped doing that's led to improvements? What has CQC stopped doing that has led to improvements? Can you just expand that a bit out, just so we make sure I'm answering the right question with that? No more is around.
Moira, are you able to come off mute to just expand on that question?
If not, I'll try to. I think it's asking what have you, oh God, are you there?
Just to say, Chris, Moira's followed up with a bit more information in the chat. So I think it's about inspection process outcomes.
Right. Okay. So I think there's been. I'll start this question off. I think one of the things that's been important for me in this time is that we've, over the past 7 or 8 months, we've been much more. We've significantly used the voice of people who use services and the voice of providers and frontline service users in our work. So we've been much more responsive to what we've seen and heard in the way we've chosen to inspect. So we've used that to guide our thinking and guide where we want to understand risk. And I think that's helped us have a much clearer picture of what it is that we need to do differently. I think that's been really helpful from my perspective, and I think it's been clearer to providers about where the issues are, but also been clearer about where some of the issues are more systemic than individual. So there's been a greater focus on individual compliance, if you like, with the regulations, but also a focus on systemic. And I think the provider collaborative reviews has helped shape that understanding there. I don't know if you want to say anything more to that, Natalie.
No, I don't think so, Chris. I think that's a really great response.
We have a hand raised from McKinsey Clark.
Hi, can you hear me?
Yes.
Yeah.
Hi, it's Kinsey Clark from Health Watch Nottingham and Nottinghamshire, and I'm the new partnership manager. So I've been in Health Watch arena for about 6 weeks, so please bear with me. And the CQC world is not as familiar to me probably as many of your attendees this morning. And my question is the notion of smart regulation is a product of COVID-19, or has this been already in the making before? And also in light of COVID-19, what at the moment, what are your greatest challenges?
Oh, I think we might have lost Chris. Kinsey, I'll take that. So I caught the second part of the question. Could you just repeat the first part for me?
Yeah, the first part was, is it sort of come about, this matter regulation, has it come about in response to COVID-19, or were you already in the process of sort of changing the approach?
Yeah, great. Thanks, Kinsey. So I think it's safe to say the strategy thinking has been taking place over the past kind of 12 to 18 months. So certainly predates COVID, but it would be incorrect of me to say anything other than COVID has certainly, I think, changed and developed some of that thinking and influenced it. So certainly from a smarter regulation perspective, we've already, during the COVID period, had to think about new ways of regulating when inspection hasn't been the right tool for us to use, but we've of course still had to uphold our statutory function and purpose around making sure that carers remain safe. So we've had to start undertaking some really interesting and dynamic new ways of working. I know Chris has already mentioned things like the emergency support framework, the transitional regulatory approach. We've also in some sectors started to explore some ideas of remote inspection and assessment. So in particular in domiciliary care services, where we've been doing a lot of work kind of undertaking phone calls and connecting with people using services in new and slightly different ways. So yeah, I think it's safe to say that certainly probably some of our thinking has come on maybe a little quicker because of COVID forcing our hand in all of this, but ultimately the smarter regulation ambition has certainly been on our radar for well beyond the COVID period. Chris, I'm not sure if there's anything you'd add.
So I did one of these very unfortunate instances where your broadband gives out halfway through. So if you saw a nice picture of me, that's because I lost my bits of my signal. So I'm sorry, I missed part of what the question was. So the answer sounded complete. I'm just conscious that there was another question that I think Christine asked, which was almost at the same time. I just wonder, have we covered that question as well, which is about what she described as lay assessors?
No, we haven't got to that one yet, Chris, if you want to take it.
Yeah, shall I? So I think by lay assessors you mean experts by experience, which are people who've got lived experience of health and care. We absolutely do see them as a vital role, not just in the act of on the ground inspections, but we've also been piloting an approach where we can allow experts by experience to engage in conversations, people using, for example, domiciliary care remotely, so because they can have just as fruitful conversations with them as they would at any other time. And the early feedback on those domiciliary care inspections is they're really very, very positive. So absolutely a crucial part of what we do now, what we will do in the future, both for on the ground inspections, but also for using experts by experience in different ways. The other thing that's important to me is that they have and often experts by experience have a network of people in their local area that have an understanding of how services are operating. So I'm keen to see how we can use that network as well of the things that they know and the colleagues know to support our understanding of how local systems are operating. Sorry, Steph, back to you. I'll let you.
Great, thanks, Chris. So we've got a question from Simon Smith in the chat, and then I think Nick Glover has his hand up. So if we go to Simon first, he's just talking about, are we looking to move away from the one large PIR submission pre-inspection and use the relationship engagements for a more routine provision of data and insight from providers?
Do you want to go first, Natalie, and I'll follow up?
Yeah, sure, absolutely. So I think it's safe to say throughout the past few years of engagement, we know that the PIR is a real hot topic. And, I think certainly we are looking to really innovate and change our ways of gathering information from providers, but as well as working with others to be able to share information in more streamlined ways. I think we are not in the implementation stages of that yet, so quite what that product looks like, I don't think we're ready to say on that. But certainly we want to be able to have providers working with us in digital ways to be able to provide that information. And like I say, the ultimate aspiration on this is we're only asking you for information that we are not able to gather from any other source. We really do want to proceed with that idea of ask for it once and use it many times, and that's not only within CQC, but that's across our systems partners who we also know are adding to that regulatory and that data burden. So would I expect to see the PIR remaining in its current form? Absolutely not. Can I tell you what the replacement for the PIR looks like yet? No. Chris, I don't know if you would add to that.
Just to say, I think one of the reasons why I think it's important to, so there is a bit about where can we gather information from, and do we have to always go to the provider? Are there any other sources where the provider themselves provides information to? And that's the point about using trying to gather it not only where we gather it, but where others gather it and use it many times. The other thing that's important to me is about how that information is used to support providers. So we're looking at whether, for example, we could use benchmarking tools to give a sense of where providers sit relative to providers like them. And I think that the idea of what I don't want the data capture piece to be is this being off into a black hole where the information comes out at the time of an inspection, but I'd rather have a more dynamic view of how services are operating, what the information is showing, and perhaps even a dynamic view and engagement with providers around, well, what does that data mean? What does it say? What's happened in an organisation? So rather than just seeing it as a rather sort of staccato, there's an inspection due, therefore the data's coming out, more of a real-time, but where it's not necessarily always collected from the provider, but more of a real-time conversation topic, so that it will help an organisation to either remain good or an organisation that wants to change what it does. It gives them a sense of where it sits relative to other organisations like it.
Yeah, and I think, Chris, just the other thing I would add to Simon's question is I think he's absolutely right around that sort of idea that we do need to move away from data collections being a pre-inspection activity to it just being more part of the day job that we're doing on an ongoing basis to give us an indicator of quality. So it's not always an all roads leads to inspection model. You know, that's a real shift that we're wanting to see and explore those ideas of actually, are there some data indicators that on their own are a significant and meaningful view of quality that don't necessarily require, you know, other associated activities. So, you know, for example, in the NHS, thinking about our effective key question, you know, we know that things like patient outcome data are you know, ultimately kind of almost the bones of that key question. Actually, do we need to do a lot of inspection activity in those spaces, or is the data telling us what we need to know and can be supported by other mechanisms to allow us to build that quality picture that can then be refreshed whenever the data or information allows?
That's great. Nick's asked a question about the vaccination programme and inspection of GPs. So just I've been looking at this generally, Nick. So doing a fraction of the inspections in primary care that we were doing prior to COVID, but we have focused our inspection activity on organisations where we have significant safety concerns, and I think that should be an important part of what we do moving forward. So are we going to do the same numbers of inspections we did pre-COVID? Well, we're not, but are we going to continue to focus where there is significant safety concerns? Because to be honest, Nick, there'd be no point having a roll out of a vaccination programme in an organisation that we felt was we had some significant concerns with. So there will be we're only going where there are significant concerns, but we are still we will still go into organisations. And of the 10,000 GPs, we're looking at probably in the sort of 5 and tens of organisations on a monthly basis where those sorts of concerns are raised. So it's a pared down programme, but nevertheless to focus on where there are genuine safety concerns in organisations. And actually, some of the action that we've taken as a regulator in those services has been quite significant, because we have got those safety concerns. So where they still exist, we should inspect, but there are no planned inspections in primary care at all. It'll, as it will in other sectors, focus on where we have those ongoing concerns. Again, I don't know if you want to say any more to that, Natalie.
Yeah, could I come in on that? It's Nick.
You can do, yeah.
Yeah, so absolutely, I've attended several of these co-production meetings, and some of you may have heard me say I have absolutely no desire to work in an unsafe industry. So absolutely, for safety concerns, as a GP and a CCG board member, I'd absolutely welcome your continued input. It really is around those services that are rated as good and who are being asked to you know, provide services for what hopefully, let's cross our fingers, will be a very welcome beginning of or at least the start of the beginning of the end, if I can put it that way. So yes, that's good. And if I could just briefly add my support to the comment that was made before about using clinical outcome data as a sort of a really good endpoint. I absolutely wholeheartedly endorse that. At the end of the day, you know, my job is around trying to improve people's health, and yes, that ought to be done in a very user-friendly and accessible way. But whatever I'm doing, if the outcomes are poor, whatever I'm doing isn't good. And if what I'm doing and the outcomes, are better than you'd expect for my matched population, then something must be going okay. So I think that's a really welcome thing to hear.
No, I agree with that entirely, Nick. That makes perfect sense. Next question is about, I think, is about measuring patient engagement. So I think a lot of this is about we're actually trying some different approaches now. There's some work we're doing with providers around what's their route to understanding how well they understand service user need and patient need, depending on what sector they're working. And we're also doing some work with experts by experience that I mentioned will help us understand that independently of them, as well as organisations like Healthwatch and other organisations that we're engaging with. So I think there's a number of routes in which we're trying to improve our understanding of how well service users engage. Often around, particularly around the links between organisations and where this is important as well. So the link between primary care, secondary care, and potentially adult social care. So some of the work we're doing in the PCRs, the provider collaborative review space, will help us understand how well people understand the care they're receiving and the relationships between the organisations that they work in. Again, Natalie, if you want to say anything more about that.
No, I don't think so, Chris. I think that's great.
What ideas can you share with providers to share best practice on lessons learned, take into account? Yeah. So, Krista, we already do. So I think there's more that we could do here. Certainly, we already run a series called Driving Improvement, which is particularly focused on organisations that were inadequate or requires improvement that would become good or outstanding. And I think using those as a vehicle to say, look, this is what's possible is really important. That we tend to look at thematically at the things that they've done, so we help understand what we can do differently. And I think we want to share as much as we can around what's working well. The idea, as Nick said, about an organisation which is good or outstanding is good and outstanding for a reason. So the idea of allowing providers to talk to each other about what they're doing, what they've learned from their experience about either becoming good or remaining good or outstanding is really important. And over time as well, we want the role of an inspector, I think, to try to throw some more of these. So the act of being an inspector isn't just about going out to inspect; it's also about sharing some understanding about what's working well in areas or different in either different bits of the locality or in different organisations, so that we're not just there to inspect; we're also there to help support and drive change and improvement. Again, I don't know if you want to say any more about that.
Yeah, no, totally agree with that, Chris. I mean, I think in some ways this is really getting into the heart of the improvement theme. So, absolutely please as well, if you're interested in that, we'll continue to be running sessions in that space as well. But I think we absolutely recognise that there's a real opportunity for us here to use our independent voice and some of our unique insights to help. We don't want to be in a position where we're telling people what to do to generate improvement, but how do we really signpost and support and work with partners in the system to be able to encourage and facilitate that. And as well, thinking outside of the health and social care system as well, more broadly around what can we learn from other industries. So particularly thinking around kind of safety-led industries, there's a huge amount of learning that spans outside health and social care, and what can our role be in facilitating that as well.
Great. Steph, do you want to take us to the next part? Yeah, do you want to take us to the next part, Steph?
Yeah, that would be great, guys. So we've literally just hit 11 o'clock. So I think everybody has their breakout room links and information. So if anyone doesn't, please just pop your name into the chat. I'll be hanging around to making sure that you guys can get over into the breakout rooms. Okay. The CQC facilitators and note takers will be there waiting for you, ready to kind of meet and greet you. Yes, so please do just let me know if you have any trouble, and I'll be hanging back here, just kind of waiting for any issues if there are.